Thank you, Dr. Ramaswamy. I'm here by virtue of the International Hernia Collaboration. I'm not in an academic institution, but the Hernia Collaboration has given us access to thousands of wonderful surgeons and wonderful people in the world whose interest is to promote the better operation for our patients. The topic is TEP, the gold standard of laparoscopic inguinal hernia repair. This is a convention for endoscopic surgeons, so we all understand that this is what we are doing. We're not here to discuss open surgery, but it is part of the discussion for today. The gold standard means that this is the procedure which other procedures have to compare themselves to this procedure. And I think the main reason is that we learned in the first day that we went to medical school that we should not cause injury to our patients. And the TEP has that particular feature that it doesn't enter the abdominal cavity. Okay, they said a left click is supposed to give the next. Oh, okay, fine. I live in Netanya, which is on the Mediterranean. It is a very beautiful city in Israel, north of Tel Aviv. This is only part of our campus. It's right on the Mediterranean. I can assure you that when I work in my hospital, I have very little understanding that the Mediterranean is just a few feet away from me. It's good to see this picture from the air. I don't have any disclosures, unfortunately. Now, the question here that we're discussing today is what I do good? When I spoke to my department chairman, we are hospitalists. We have also private practice, but we are basically hospital-based. I told him that I'm going to speak about TEP, and he's done a couple thousand of them. And he said, well, what is there to talk about TEP? And I said, well, you know, it's just a symposium, so we're starting out with TEP. But really the question is are we doing the right thing for our patient? And the goals of hernia surgery, we all understand what they are. We want a smooth, quick, and pleasant operation for our patients. We hope that it should be complication-free. We want minimal postoperative pain in the early period as well as chronically. We want our patients to go back to their activities and their work as soon as possible. And we do not want to have recurrences. So there are goals. And there are many ways of accomplishing this. The open procedures have many different procedures, mesh-based and non-mesh-based. And most of the surgery in the world is done open today. About 10, 15 years ago, laparoscopic surgery was about only 10% in the United States. Now I understand it's more like 30%, but still 70% of the operations are not being done laparoscopically. The intraperitoneal onlay mesh is actually an old procedure, one of the beginning procedures in the early 1990s. It ran into disfavor because of the difficulty in really seeing what the anatomy is with fixation problems, nerve injury problems, and recurrences. Then we have the TAPs. Actually, endoscopic surgery for hernia started with TAP, and then it went into TEP later on when people realized that entering the abdominal cavity may not be the best interest of our patients and because of complications that could develop. So laparoscopic inguinal hernia repair is a tension-free preperitoneal repair, and the point of this slide is that the original posterior approach that was developed, and Dr. Reed was one of the people who operated, and they did close the defect from inside. I was brought up with the Schuldeis technique and then the Lichtenstein technique, did hundreds of these operations, but for recurrent hernias, I got into the preperitoneal procedure, which was an excellent procedure using mesh because we were already into the tension-free era. And then the laparoscopic developed from this idea that we should not try to do a tension repair from inside the preperitoneal space. In the early 1990s, there were already multiple individual series of TEPs. Dr. Ed Felix, who I think is here today, and Dr. Guy Veller produced individual series that had a 0.6% recurrence rate, an excellent recurrence rate, which is much different from the 10% recurrence rate which was reported in 2004 in the New England Journal of Medicine, the large series that everybody knows about, and they recommended that open surgery should be done rather than laparoscopic. But individual people were able to achieve fantastic results with the laparoscopic procedure and the TEPs. And then the question comes in, are we evidence-based or are we evidence-based? The idea of evidence-based is how I got into this idea. Met Guy Veller, I went to see him about 20 years ago in Memphis, and I fell in love with the procedure because you saw an excellent, beautiful, elegant procedure being done, and you knew that this patient had a good repair. But the question is, how is that reproducible in the world by everybody else? So then you get into the idea that we have to have evidence that it's a good thing to do to our patients. So evidence is something that's been systematically collected, critically evaluated, and properly synthesized, in the words of some people. And I think most of us are probably evidence-based. And the question is what and how to evaluate it. And of course, you want to evaluate the chronic pain issues. You want to evaluate how long it takes to do the surgery. You want to know how long it will take for your patients to get back to their activities. And what does that mean? Does it just mean that they can go outside and walk around, or does it actually mean they get back to their work? And then there's this concept of quality of life. Quality of life is actually something that's measurable by certain forms. There's a SP36. They ask questions of, are you depressed? Do you feel down? Do you feel tired? All these different kind of things. And then you have this specific quality of life issues. As we see the Carolina's equation for quality of life, which is a preoperative assessment of how likely the patient will be to have chronic pain after the surgery. These are quality of life questions that are related specifically to inguinal hernias. And then the question of recurrence rates has to be studied, and then the cost is also a big question. What do you mean by cost? Do you mean just the equipment, or do you mean the operating room time? Laparoscopic surgery requires general anesthesia. Sometimes in my hospital or in hospitals I've worked in, it takes 20 minutes for the anesthesiologist to intubate the patient and put the patient under general anesthesia. And these things cost money in certain settings, not in every setting. In my hospital, in a socialized medicine situation in Israel, it doesn't cost money if they take 20 minutes longer. So then we have these randomized controlled studies. There are myriads of these. And the question is, who are the surgeons that are doing these procedures? Are they well experienced? Are they less experienced? And all of these different studies do try to state how much experience these patients have. There's one large study by Eckert in which one surgeon was responsible for 38% of the recurrences. And then you had to take out that particular surgeon, and then you saw what the recurrence rate is likely to be. Also, what was found from these particular studies was that the learning curve for doing surgery well, endoscopic surgery well, is very, very high. They originally thought it was about 25. Now, then it got over to 250 procedures had to be done before you would be able to say that you have a good recurrence rate. And what many organizations did, European Union trialist collaborations, different groups, the Cochrane collaboration, the National Institutes for Health and Care Excellence in Britain, they published very serious meta-analysis in order to understand whether these trials that compared laparoscopic versus open procedures were working. And the conclusions, basically, there is less early postoperative pain, there's quick return to work, quality of life is basically improved, there are fewer postoperative complications. The question is, what does that mean? A lot of these studies compared TAP and TEP as opposed to open procedures, and there were some major visceral injuries in the TAP procedure. So you have fewer postoperative complications because you don't have the surgical site infections with the laparoscopic procedures. But there are a few major problems. less than chronic pain and numbness. Now, the same recurrence rate, what does that mean? That means only if under the condition that you're dealing with a very experienced surgeon. And we all know it's better for recurrent hernias, it's better for bilateral hernias. There is a longer operating time, and then, of course, we just discussed that. It depends on what you're dealing with. TEP versus TAP, no invasion of peritoneal cavity. You have less visceral injury. These have all been shown. Fewer missed lipomas, which is an issue, and there's a quicker exit. You don't have to close the peritoneum. The International Indoor Hernia Society is a paucity of published data with level 1 evidence comparing TAP versus TEP and their advantages and disadvantages of both. And it is recommended that people should know TAP as well. And that's not so simple if you were brought into an area where it's only TEP. Will TEP become the gold standard of inguinal hernia repair? I doubt it. Recently, I had the occasion, mentoring a younger surgeon who has done about 25 of these procedures. Very difficult to see somebody doing a TEP procedure. It takes a lot of experience to get to where we are today. And there are a lot of difficult issues in TEPs. Fixations, the choice of meshes, there are many, many issues. And I think that is TEP the gold standard of laparoscopic inguinal hernia? I think it is. We know that it's good. It's a very good procedure. And in conclusion, I think there will always be changes in inguinal hernia surgery. TEP, for the time being, is on top. Thank you very much.